Thank you very much, Dr. Kudlu. So we go on to, thanks for everybody's patience. We'll go on to the last but not least presenter. And I request Dr. Bhalla to please introduce the last speaker.
Dr. Bhalla?
Dr. Bhalla, sir, I think you are muted. You are muted.
Unmute. Hello. Dr. Bhalla?
I have the privilege of presenting the last case presenter, Dr. Ayan Mohanta. Dr. Ayan Mohanta joined Disha Eye Hospital and Research Center about 20 years back on December 1st, 2001. He has performed numerous cataract surgeries and refractive surgeries, both LASIK and also Phakic IOLs, ICL and IPCLs. He is one of the prime phaco trainers at Disha Eye Hospital. He did his MS from Regional Institute of Ophthalmology, Kolkata in 1997 and MBBS from Neel Ratan Sarkar Medical College from Calcutta in 1991. Over to Dr. Ayan Mohanta for the last presentation of this wonderful webinar.
Thank you. Thank you very much, Dr. Bhalla, for the kind introduction. Good evening, everybody. And I especially thank... Hello.
Can you stop the slide share, Dr. Bhalla?
Yeah. I especially thank Dr. Partha Vishwas and entire scientific committee team for giving me this opportunity. So, are my slides visible?
Yes, sir.
Yes.
Yeah. So I'll be talking on Phakic IOL with cataract management. So I don't have any financial interest to disclose. At the outset, I would like to begin saying that cataracts these days with the most advanced type ICLs are extremely rare. And recently they have, not recently, I mean for the last 5 years, they have come up with a central hole, ICLs with central hole. And in a study, they have found the incidence of cataract being nil. The causes of cataract is being the low vault. Ideal vault is 150 microns, which is recommended because of decreasing vault over time. So this is one such case in which you can see that the lens is a bit eccentric and the central part looks okay, but if you go to the peripheral part, the ICL is touching the periphery of the crystalline lens. So these all things lead to cataracts. In one study, they have found that anterior subcapsular cataract developed due to injection of BSS jet through the hole, impinging on the lens capsule. Also, flipped ICL is a cause of cataract. Excessive manipulation, like Dr. TTL said, if you have a upside down ICL, never attempt to correct it inside the anterior chamber. It's better to take it out and then reinsert. Also, there is a trapped viscoelastic material below the ICL. It looks like cataract. And sometimes I have seen in my personal experience that this leading to anterior subcapsular opacities. Also, the myopic eyes develop cataract early. And there is always the presence of senile cataract. So these are some of the preoperative considerations. Biometry per se is not a problem because ICL does not hamper with the biometric calculations. Extreme axial length considerations are to be done. Whichever formula suits you best, go for that for calculating the IOL power. Specular microscopy is better be done because you are doing another surgery, and if you have a low endothelial cell count, you can warn the patient that you have a low endothelial cell count, so you might land up with corneal problems. The choice of anesthesia is topical, preferably. Incision location is temporal. Those who operate from the head end, they have to keep in mind that the ICLs are placed in horizontal axis, so you have to rotate the lens to 12 and 6 o'clock and then take it out. The type of cataract is usually anterior capsular with occasional fibrosis, so your armamentarium should be okay. You have to have micro scissors sometimes. And these are all myopic eyes. So phacoparameters are to be on the lower side. You have to reduce your bottle height and you have to reduce your IOP if you're using a Centurion machine. So this is a IOL explant with a ICL explant with a IOL implantation. So we go in for a 3 millimeter incision, fill up the anterior chamber with viscoelastics to prevent the endothelium from getting injured. I personally prefer to bring out all the haptics because this case was done somewhere else. So you never know, there might be adhesions in the periphery. So while you're pulling the IOL, it might injure the iris as well. So it's better to bring out the haptics and then pull it out. It gently unfolds on itself and comes out. So the rest of the part is like simple cataract surgery. So you fill the anterior chamber with viscoelastic, do a rhexis. And one thing you have to keep in mind, you have to prevent chamber fluctuations. Since these are long eyes, the chamber fluctuates to a great extent. So the hydrodissection is being done, the nucleus is rotated, and mostly these cataracts are soft cataracts. They come out very easily. And as I said, that the phacoparameters are to be on the lower side. The bottle height should be low. And your IOP, if you're using a Centurion machine, should also be very low. I prefer around 26 millimeter of marker in my machine. And when I am taking out my phacoprobe, always remember to fill the anterior chamber with viscoelastic because otherwise the anterior chamber is going to collapse. Cortical aspiration is being carried out. And you can see the large PI in the right-hand side. This was expand series lens with a -1 diopter. It goes in. And I usually orient all my lenses in supernasal and inferotemporal orientation. And again, before bringing out my irrigation cannula, I tend to hydrate the wounds. And this is another case in which the ICL was flipped. That is upside down ICL. You can see a cataract that has developed and there were plenty of pus in the periphery. So again, copious injection of viscoelastic and taking out haptics one by one. With the olive tipped applicator, I found it very difficult to bring out the ICL because the ICL now it has become a concave in nature, so it would not engage. So I took a Sinskey hook and gently took it out in the anterior chamber, and then grasped the lens, and you can see it was flipped because here you can see the holes, the leading left and trailing right. So it's a flipped ICL. So this is a very interesting case, a varicose phakic IOL done long time back. So these cases you might find one occasionally. So you measure the diameter of the lens and then it's at 4 millimeters. So it's better to go for a scleral tunnel and bring out the lens. So here, I think SICS would be a preferred option. You can do a phaco from making another tunnel somewhere else, but that will lead to further trauma. So here again, filling up the anterior chamber with viscoelastic. The enclavations are disengaged. And while doing so in this one, part of it broke. Be careful to take out the broken particle. And now while taking out, I found some resistance because of the sharp edges. In such a case, it's better to rotate it and then bring it out smoothly. Thank you very much.
Thank you very much, Dr. Mohanta. I think that was just a fascinating series of cases that you showed us, and a lot of good points in how to explain the ICL. In fact, interestingly, just very recently, I had a patient who had bilateral, was operated elsewhere and had bilateral cataracts after ICL. And in one eye, the ICL was flipped, and in the other eye, they had actually inverted the flipped ICL. So it was, for me, it was the right side. And the ICL which was not flipped was much easier to remove, just like exactly how you showed. But the ICL which was flipped, I did exactly the same technique, put the Sinsky and then disengaged it. So it was good to see that. And that was just guesswork on my side. So it was good to see you do that.
Yeah.
So did that wonderful presentation. I think we did save the best for last, looks like. We'll go to the discussants for this particular session. And I'd like to ask our chairperson first to start off and discuss how does he tackle such cases of cataract management after ICL.
Okay.
Phakic IOL.
Yeah, thank you very much, Dr. Somshila. I'll just, the presentation was nice and I think he made out all the points, but I'll just wish to emphasize some points and some differences in what I do. The first important point that he made was that an IOL power calculation is least of an issue. So you have to put your normal formulas, which you do, because the thickness of the ICL is very little and that can be negated, and there's nothing much that you need to do. The second thing which is important as regards doing it, I normally prefer to use what he showed later. I use a Sinsky hook to actually nudge from the hole, so that I just bring out the upper haptics. I don't need to actually work on the lower one, because they will automatically come out if you pull it out. The second thing that I wish to say is that you should always have, now that you have phenocaine available, you should always have that, because sometimes when you pull it out, there is a rub on the iris and the pupil may come down. So you need to kind of have that ready so that you can use it. Now, I always, when you get the hold of the upper haptic, I normally do not use a McPherson forceps at all, because it tends to slip at times. So I would, even if I have to use a McPherson, I'll do a hand over hand technique. That means I hold it, and then with the other one, I bring it out and then I pull it out. So it's so that you actually get a meet of the a reasonable amount of length in your grasp before you are actually pulling it out. Because if you're just getting the tip and trying to pull it out, you can often get a tear at the where the hole is, and you can have a problem. So that is something, because it's thin in the periphery also. So that is something that I do a hand over hand technique. And if you have to use something like a McPherson, I would prefer to use a capsulorhexis forceps, because that gives a slightly better, because there's a bend and it gives you a slightly better hold. That's just a individual variation that I do. But nowadays I've started using the smile curved forceps that we have, and that gives you a very good hold, and we can actually remove the ICL much easier. So a couple of things that I wish to highlight, that is about all that I will wish to say. Always I will prefer a Sinsky, only remove the top part of the ICL haptics, do a hand over hand technique, and use something different from a McPherson to pull it out, and use phenocaine. Now, one thing which obviously does not concern a lot of people is that when you're using a femtolaser platform, for doing a femtolaser on these particular cases, at times the femtolaser gets, the OCT of the femtolaser gets fooled. Because it will pick up the ICL as the top part of the lens, and you will have to actually do a default setting. So I have had this problem once or twice, more so in the LensX machine than with the Catalyst machine, and therefore it becomes very problematic for you to actually work with a half-cut capsulotomy and remove the lens. So I have actually given up doing a femto in these procedures, because you have a free-floating capsulotomy or a half-cut capsulotomy, and you're trying to pull it out. So if something goes wrong, then you have a problem, and then locating the edges of the capsulorhexis becomes a problem. So I normally wish to not work with a femtolaser platform in case of a ICL where I have to do a cataract surgery. And because of the anterior capsular opacifications, which are quite often there, I would prefer to use trypan blue also if required in these particular cases. So these are a couple of the tips, and normally these cataracts are pretty soft. So you're not using much of a phaco energy in these particular cases. Even if you have a nuclear sclerosis, they are not tough cataracts, and they are soft cataracts which we can remove out well. So these are a couple of the things that I'll just wish to say. Overall, an excellent presentation of the various ways that he can work with removing the ICL and then doing a cataract surgery.
Some of the surgeons, sir, some of the surgeons, they keep the ICL in the anterior chamber, they do the phaco, and they once again re-implant the ICL after the IOL implantation. What is your take home?
Sorry, there was a point that I wish to actually add is that I use a lot of viscort or a chondroitin sulfate in all these cases to protect the endothelium. That is something that slipped out of my mind. I always have chondroitin sulfate and a specular, because you are dealing, at times you can rub the back of the endothelium and cause a problem, and wherever it gets rubbed, you can have an issue. I have never done that because I really don't know what purpose that is going to serve, that you are keeping the ICL and then putting the lens and trying to work through that. I think it's more to show some people that we can do it this way, but otherwise I don't see as to what purpose you are, because typically most of our ICLs that we are doing are myopes, and they have deep chambers, and you're not coming, it's not a question of protecting the endothelium from that. The only time that you need to protect the endothelium is when you are explanting the lens. Otherwise it's a normal phaco that you are doing. So I don't try that heroics to have the ICL in place and put the lens first, and after putting the lens, do the phaco, then put the lens and then remove it. No, I haven't done that, nor do I see any specific advantage over it. But viscort chondroitin sulfate is a must, which thanks for bringing it out again regarding the corneal endothelium. We want to do and preserve that.
Dr. Kudlu said that we'll implant the same ICL. We cannot do that because IOL power.
No, that's a different power. I don't think he said that. I thought he did. You mean that, Kundu? If he said that, that doesn't make sense.
Like I have seen Sri Ganesh, one of the video, he was showing that one of the Sri Ganesh video, that he got the ICL into the anterior chamber, he kept it aside, did the phaco, once again he implanted back the same ICL. I was very much shocked to see. So I need your opinion.
Actually, sir, that was a case of high myopia where he was not able to get probably a lens of that particular diopter, I think.
No, but Sonu, that's obviously not possible. Yaar. Usme to bahut
IOL power calculation will be altered.
It was an award-winning video in one of the ICL user meet, and what he was emphasizing was that the ICL was kept, and he did cataract, and he could calculate the IOL power, and maybe +4 or +5 as far as I remember, few years back, sir. So probably a very extreme of myopic conditions he was trying to show.
You mean for an IOL which he was not able to get, he used that as a piggyback and used another power.
Correct,
so it was
correct.
available.
The ICL was being used as a piggyback kind of stuff.
Formulas could be pretty
What is
different.
the basis of IOL calculation in that particular case?
Yeah, that's what.
So since we don't have that case here, maybe we won't discuss, but definitely the same ICL cannot be placed. It's possible that they may have done a calculation and realized that they have an ICL of that calculation which could have been placed. That is what I'm assuming. Or there could be a piggyback ICL used, because you might have one IOL and then you still are deficient, and then you might have used an ICL as a piggyback. But otherwise you just can't.
Or maybe you used an aura.
Okay.
That could be a possibility. You have that and do an aura and see what. I don't know.
Maybe. So we
Not
go to
possible.
Dr. Biswas just because we're really on time, not on time. So Dr. Biswas, we need your comments now from the master.
Thank you very much, Somshila. And to tell a small take is, when I asked Ayan that Ayan, would you be comfortable to talk about cataract with ICL or IPCL? Is it possible? So he said, obviously, I've done so many cataracts in which ICLs and phakic IOLs have been implanted. And I nearly believe that all the cataract patients have gone to him, for which possibly I did the ICL or the very second. So, having said that,
So basically, you are asking him to give you something in return.
So that's an honest confession.
Modest
Huh,
of you, Partha.
Very
So-
honest.
Can I make a last comment? Partho,
sir, yes, sir.
I think, as far as cataract is concerned, in a post-phakic IOL series, I have also done multiple cataract surgeries for a patient who had undergone ICL surgeries. And this is published in Eye also. And we realize now in the recent generation ICLs, the cause of cataract surgery, the requirement of cataract surgery post-ICL is not because ICL vault-related problems.
It was because mainly I had 50% of the cases because they had a vitreoretinal problem where I had to do a cataract surgery for vitreoretinal surgery. And there were one case of inverse ICL and one case had a severe glaucoma and inflammation. So we realized that cataract formation in today's generation, not because of ICL ball related problem, it is mainly because of other assistance required for a BR surgery was a major indication for cataract surgery in our series.
Also, Dr. Tityal, don't you think that the high myopes that we have, the onset of senile nuclear cataract is higher, is about a decade earlier? And so if we operate on these patients who are in their mid-30s.
That is what Dr. Mahipal talked about in the beginning. We do have patients come with a nuclear sclerosis much earlier in these group of patients, though we don't have a case control study to prove that in myopic patients with ICL, they'll have early onset. But we do have myopia patient coming with these things. But I've seen cases with my IPCL series also. I've been using IPCL for last 3 years now. I've already done at least 3 or 4 cataract surgery in these patients because these are an older group of patients because I'm using a presbyopic IPCLs for last 3 years and these patients are 40 plus. And I agree to Dr. Mahipal correctly. These people do have early, nuclear sclerosis and they demand surgery because the correction goes haywire after ICL, IPCL.
So one or two small
I
points.
think, sorry.
Yeah, go ahead, sir. Go ahead, sir.
I think Dr. Ram also said, you also said, I've done a couple of IPCLs, but both of you seem to have, it's a reasonably recent lens, maybe 3-4 years old or 5 years. I don't know. It's not as old as ICL.
6 years.
Yeah, whatever. So why are we getting the cataracts? Is it that in the IPCLs, the cataract tends to happen earlier than ICL?
A word. I mean,
no, sir. I said because I am using presbyopic IPCL, so my patients are 40-year plus.
I heard that you qualified that, but Dr. Ram, I don't think has used all those as presbyopic, and he says that he has also done with IPCL. So I'm just asking that in the feeling of the panel, does IPCL, is there a higher percentage of having a possibility of cataract as compared to the latest generation of ICLs?
If I might just add on, frankly, I don't think the type of lens really matters. And it's been a published study from Zaldivar years back, where he says the chances of cataract developing increases with 3 factors. One is, of course, the sizing, lesser the sizing. And second is the higher the age. More beyond 40 years, more the incidence of cataract. And third factor is a power of beyond -15. So these are the 3 factors. So obviously, as Dr. Somashila said, all these high myopes as such have tendency for nuclear sclerosis to come on earlier. So I believe that if it's only anterior subcapsular fibrosis, you can really blame the lens. If it's a nuclear sclerotic cataract, maybe the patient would have developed that even without the phakic IOL being placed.
But there is a factor of lens metabolism changes happening with ICS in the long run. So we are not sure that might cause the nuclear sclerosis changes coming up also.
I mean, that's absolutely right. And that might be the reason these patients get it. But that would have been a greater problem with the lenses where the central hole was not there. Now with the hole being there, the circulation of the aqueous is supposed to be quite...
yeah, but Dr. Mohanta did an excellent picture. Peripheral touch, obviously there has to be a peripheral touch, so I think it might be causing something on the metabolism. We have to do a case control study. I really don't know how we can do it with one eye and ICL and the other not an ICL. Could be an anisotropic eye, and you would say that it's because of high myopia. But anyway, that's just a feel, because there is a touch on the lens in the periphery. Even if with the vault you have a hole, but there is a significant amount of touch in the periphery, and the photograph was brilliant. I think, Dr. Mohanta, that was an excellent.
Let me share one more my experience within IPCL and ICLs. The material does make a huge difference in a ball, especially when you have a meiosis or a pupillary dilatation. If you see the change of ball happening with meiosis and dilatation much more with the IPCL than ICLs. That I have seen in ICL, people are reported the change can be around 50 micron plus minus 50, around 100 is this thing. But in IPCL, this is much more. And the vision changes significantly with the meiosis and the pupillary dilatation.
And one additional point I would like to add here is it was both regard to Vardhaman as well as the Ayan's presentation. My indication for removing a ICL would be really an onset of cataract. I have a few patients who have a vault. I mean, Vardhaman's case had a vault of 115. If the anterior capsule is quite clear and lens is quite clear, I would still observe these patients. I think even the Mark Becker's study shows that it's a multicentric study, and it shows that even from 100 microns to 1000 microns, patients have been followed up without development of glaucoma or cataract. So obviously 250 to 750 would be the right measurements, but then if the chamber is deep, the IOP is okay, and there's no onset of cataract, you can sequentially follow up these patients along with a good gonioscopy, and do not be in a hurry to remove these lenses. Often there's a sign of a cataract develops a little periphery, not in the center. Once you see a cataract developing, maybe then it's time for you to interfere and take the lens out.
So I think what you mean to say, sir, if there is a peripheral touch and there is a subcapsular cataract, and if it is progressive, that's an indication for the expert.
Absolutely. And another, all these details, maybe this was shown here, but they are not supposed to be sitting on the lens even peripherally. They are supposed to be floating around in the sulcus, though, I mean, that's what the company claims. I mean, that's not really touching on the surface of the lens. Maybe if you size them appropriately, it should be like that. And that brings me to another point which Kudlu made, that is, he had high vault and rotated it from horizontal to vertical. That would actually increase the vault, because most often the horizontal white to white is larger than vertical white to white. So I'd rotate it if the vault is low, but if the vault is high, I don't think a rotation to a vertical axis would really help.
I think the internal sulcus vertically is much higher than the horizontal. So I think with the higher vault, if it is horizontally placed, you can flip it vertically so that the vault goes down by 100, 150 microns.
Yeah,
I think
it's around 300 microns. It goes down.
That is what my understanding is. Because the internal sulcus to sulcus vertically is much more bigger than the horizontal.
One or two small points, if I can just make. Ayan showed actually excellent explantations, but at times there are a few compromises and a little bit of difficulty, especially if a younger surgeon is doing. One thing is the dilatation of the pupil. The dilatation of the pupil must be as large as possible in such cases, and the use of the viscoelastic, what Mahipal sir said, is very, very important to get those haptics out. And once the haptics are out, then it becomes important also the incision where we are putting in the phakic IOL. When we put it in, then it is nearly horizontal. But when you're explanting a phakic IOL, the incision must be a little dipping down so that the haptics, when you're taking out, get into the incision site very easily. Otherwise, if the incision is very flat, then it has to be tipped up, and there is a difficulty in grasping and re-grasping the foot plates. So that is one thing that I just wanted to share. The other thing is the iris. If the iris by chance comes into the way, then you have atonic iris, which will gradually come down and make things difficult. So these are a few things about what I just wanted to say about the explantation. Otherwise, the explantation is a very nice way, and it can be very simple. The forceps are very important, and the end-holding forceps that is used is very atraumatic, and it pulls out the columbal lens extremely easily. Another thing that I think we just missed out on is the white to white. And initially, when we started off with the phakic lenses, and especially with the ICL, we used to do it with the OBSCAN. And that was the standard that was said that the white to white with the OBSCAN is the standard. And it really stayed as the gold standard. And then, of course, most of us went on to the caliper because the OBSCAN was not available most of the time. So right now, the caliper is one gold standard that we are using, and the other is the Pentacam HR. Also gives a good white to white and quite an accurate white to white. And as was said by all the speakers, that the IOL master and the oculizer actually overreads the white to white.
Partha sir.
Yeah.
Just white to white, one small doubt I am having. Like people tell that, see, Vardhaman presentation, he told that mid limbus to mid limbus. But few of the people, they say that it is from the black to black, where the black ends. If you measure that, it's perfect. But I need to know from all the expert whether mid limbus to mid limbus or white to white, or the where the black ends till the black.
Okay, Ayan wants to answer that. Yeah, Ayan,
No,
please.
not answer. I want to show a video on that. Is that allowable?
Yeah, allowed.
Okay. Fine. Go ahead, Ayan.
There are no charges on you. We will take.
Previous one is not going.
Stop sharing the previous slide.
I am pressing on new share.
Sunilji, can you stop the slide share for Ayan?
Why? Yeah.
Yeah.
That same thing is coming. Anyway, I think I should quit.
Actually, while he's getting ready, just a comment about what you said, Partha. We measure both with the digital calipers as well as the OpScan or the topolizer vario. And usually what we make sure is both these things correspond, the horizontal white to white. Sometimes if you have a small pigment or a blood vessel or even a pinicula at the limbus, the instrument fails to, the topographers fail to recognize it and may include it into the white to white. So we make sure that the two factors line up. If these two are nearly the same, then we go ahead and use the values given by the topolizer vario. And as was said, IOL master and anything using laser interferometry gives you a slightly larger reading because they measure not white to white, but sclera to sclera. So that's the reason there's a difference of about 0.4 to 0.5 millimeters. But I think if you're using calipers alone, it's a good idea to take the patient to the theater, make them lie down under the microscope, and you put a speculum in and measure. That will definitely give you a more accurate reading.
Is this visible?
Yeah, very well.
So this is 10.82 and this is 11.72. Now what should I take? This is the other eye. This is the left eye. This is 10.82 and this is 11.72.
So what I see there, the 11.72 was definitely on the white side, and the 10.82 was definitely nearer. But we would definitely have to compare the right and the left, and if whichever is as equal to the other is what would be the best guess.
The other eye is 11.12. The other eye has got 11.12.
But 11.12.
Yeah.
But 10.8 here, I think then comes the other instruments also. Then the IOL master and the oculizer also need to be seen whether this big difference is coming, because this is very unusual. If such a big difference comes of nearly about 0.7 to 0.8 microns, then 0.7 to 0.8 millimeters, then that is not an acceptable difference.
Let me answer Kudlu's question. I think it is the way you're going to measure every case of yours. So you have to have your own landmark, which you are going to do for your case. And you'll have a series of your patient, and you will rely on that particular anatomical mark. It can be junction, it can be white to white. You have to decide what is your landmark, and then have your own. Like we talk about A constant, you have to have your own landmarks. You can't rely on others parameter in these cases. So if I'm doing a just inside, or if I'm doing a just at a junction, every case I'll do a junction and compare with my other instrument. Then I'll have an algorithm of my own corrections, because they can.
Yal is saying is very right. You have to have your own gold standard as to what you're using, where you're using. So like what Partha said, we always have a pentacam reading also with us as regards the white to white. I never use the IOL master, but we have a pentacam reading, plus we do the digital, plus we do the other eye. So if there are discrepancies between the three of them, between one eye versus the other eye, as also between pentacam and the digital caliper, if there is a lot of discrepancy, then we will go ahead and redo it, and then there is a problem. But you have to have your own gold standard as to what you are using as a measuring technique, and the digital caliper is our gold standard in center of sight.
Thank you.
It's extremely unusual to have such large differences between the two eyes. Because,
I think the eye was moving a lot. I think the accuracy of the reading was slightly, could be a little better.
I think I would correlate vertically also, sir. In this particular eye, measuring vertically also could give you a small clue to the exact measurements.
I think Sonu, you can always play with your way of measuring things. If I have to have a topography and show that my topography is equal or different, I can just take in 10 minutes and 2 topography readings will be there. Similarly, when you are doing a white to white measurement, it's the position of the eye, how flat patient was, the head position, the tilt. That makes a huge difference. If in the same eye I can have a 10.8, and same eye I can have a 11.2 also, the way I measure it, the tilt in the instrument, the tilt in the eye, all these things has to be looked into.
So if we were to err, for example, it's a very close call between, say, 12.6 or a 13.1 ICL, would you err towards a higher size or a lower size? A general question